afternoon, dear colleagues. It's a very big pleasure for me to stay again another time in London after the first Hyperacusis conference on Hyperacusis and the second also. And so thank you very much to Hashir for the invitation. I am Alessandra Fioretti. I am an ENT, doctor and audiologist. Yes. And I work in a Tinnitus Center in Rome, Italy. And we work together with a multidisciplinary team. So there is the ENT, the audiologist, the psychologist, neurologist, radiologist. All the team work together. And we treat many patients with tinnitus, some patients with hyperacusis, and in the last years we have increasing number of patients with misophonia. So today we will introduce you our experience from ENT point of view and psychological point of view with three representative cases of patients with misophonia. So we treat patients with tinnitus and also with decreased sound tolerance. And from the ENT point of view, we have to evaluate first the history of the patients. It's very important because the history gives us many important elements. And so it's possible to distinguish between the different forms of hyperacusis, or phonophobia, or misophonia, or we have also a limited number of patients with acoustic shock. For example, in call center operators, we treat patients with this disorder connected with the tonic tensor tympani syndrome. And the question for the patients is very important, for example, to evaluate the previous head trauma or acoustic trauma. In many patients we find these problems before. But we have also increased number of patients with multiple sensitivity chemical as proposed by Hashir in the first presentation. And in this case, the hyperacusis is very, very severe. It's very, very difficult to treat the patients with this disorder because they have many other hypersensitivity, for example, for odors, for the smell. So these kinds of patients are very, very difficult to treat. And we have also the opportunity to study the patient from the audiological point of view with poor tone audiogram, with autoacoustic emission to evaluate the functionality of the inner ear. And also we use the LDL or ULL to consider the presence of hyperacusis. And the cutoff proposed by Moore and Hashir is very, very important because we have a point of start to evaluate the patients. So, also the questionnaires, for example, we use the CALFAS questionnaire, and it's useful for the quantification of the hyperacusis, but we found some limitation with this questionnaire. So, can we distinguish hyperacusis and misophonia with the global evaluation? Yes, because in our experience in hyperacusis we found normal hearing, and the LDL are altered. But if we study the inner ear, for example, for autoacoustic emissions, the function is normal. And the questionnaire, the CALFAS questionnaire, in the case of hyperacusis, is positive. It can be a mild hyperacusis or a severe based on the score, but this is useful for the follow-up of the patients. In case of misophonia, we found normal hearing, normal LDL, a completely normal inner ear. So there are no problem in the in the ear is confirmed by the exams. But if we consider, for example, to exclude the presence of hyperacusis in a patient with suspected misophonia, and the CALFAS questionnaire is positive, because it's a questionnaire sensitive for decreased sound tolerance, but it's not specific. So if we do this questionnaire with patients with misophonia, we found also a positive score, but it's not useful to distinguish the patient with misophonia and hyperacusis. We actually use the CALFAS questionnaire because we have proposed and published some years ago the Italian version. So in Italy we use this kind of questionnaire. But we think that in the future is necessary a new psychometric tool. And now I will show you the characteristics of our 3 cases. And these data are under review for the publication. So the first case is Roberto, is 46 years old, is a manager and has a stable romantic relationship. Does not tolerate the sounds and the sight of people who chew with open mouth or with voracity, so crunching sounds and chewing, eat nails, snore and clicking. And the second case is Helena. She is 41 years old, is a professor, she is married and has 2 children. The trigger sounds for her are swallowing, chewing, eating nails and sneezing. And the last is Georgia. She is 25 years old. She does not have a relationship and she is a university student. And for her, the trigger sounds are chewing, barking of dogs, tooth cleaning with a toothpick and kisses. From the ENT and the audiological point of view, all 3 patients have completely normal hearing, completely normal LDL, and completely normal inner ear function evaluated with autoacoustic emissions. But, for example, CALFAS questionnaire administered was positive for all the patients, so it's not specific for the cases. Now I will introduce you our Eleonora Natalini. She's a psychologist and psychotherapist, and she will show you from the psychological point of view our patients.
Okay, thank you, Alessandra. So I'm going to explain the psychological part of this study. I hope to be clear and not bother you with my English pronunciation. And my English teacher has also misophonia, so he didn't kill me, so I hope to be safe also today with you. So we can start with the instruments. We utilized the Amsterdam Misophonia Scales for misophonia, the SCID-2 for personality disorders, the Young Schema Questionnaire to investigate maladaptive schemas, and the last questionnaires about depression and anxiety. So, but what is a personality disorder? So, personality disorder is an enduring pattern of inner experience and behavior that deviates markedly from the expectations of the individual's culture, is pervasive and inflexible, has an onset in adolescence or early adulthood, is stable over time, and leads to distress or impairment. While a nearly maladaptive schema is a broad, pervasive theme of pattern comprised of memories, emotions, cognitions, and bodily sensations regarding oneself and one's relationships with others, developed during childhood or adolescence, elaborated throughout one's lifetime, and dysfunctional to a significant degree. So, these are the results for the questionnaires. All three patients have severe misophonia, and all 3 patients have a personality disorder, in particular obsessive and compulsive personality disorders. Georgia has also avoidant personality disorder, paranoid personality disorder, while Roberto borderline personality. For Georgia, depression is severe, while Roberto moderate. Anxiety is moderate and severe for Georgia and Roberto. So, this is consistent we can see a severe depression for Georgia because she has a lot of personality disorder and dysfunctional traits. So, these are the results for early maladaptive schemas. Georgia, in fact, endorses maladaptive schemas in all domains. Roberto also shows many schemas. In particular, he feels deprived, abandoned, self-sacrificial, and approval-seeking. He has no self-control and he is a perfectionist. The same for Elena, who suffers only from OCPD, is mostly perfectionist. The schema named Unrelenting Standards Hypercriticalness is a sign of perfectionism, is the most relevant in all 3 patients, which is inconsistent with the OCPD diagnosis. So, I show you some narrative episodes that the patients told to me. For example, Roberto was sitting in a bar and heard a crunching sound that caused a reaction of anger. But when he realized it was a bird, the annoyance suddenly disappeared. Roberto is normally irritated by the snoring of his partner, but that day he felt guilty for something he did to her, and significantly no misophonia was experienced. So, I suggest this solution, but Roberto didn't find this type of bed, so I don't know. The problem is there. So, other narrative episodes. Elena noted that when misophonia is caused by her husband, all symptoms suddenly disappear if he shows affection and embraces her. The same sound, okay? Moreover, if she believes that the sound is legitimate, misophonia does not arise. For example, this happens if her mother produces sounds while drinking to take a drug. Okay? It's alright to drink to take a drug. Okay. Georgia wears the headphones when the neighbor's dog are barking and she thinks they should not live with a dog in a small apartment and leave it on a balcony to annoy other people. They are really ignorant and rude with animals. Okay? So, obviously, it's not his fault, obviously. In this case, the guilt is of my sisters. So, this is the face of Enea, the name of the dog, and all the time she goes out, this is his face. So, it's so difficult to go out all the time. So, conclusions. All 3 patients reported that trigger sounds elicited negative emotion and behavioral reactions only if mediated by specific cognitive interpretation about the source of the trigger sounds. For example, Roberto with the bird. When patients interpreted trigger sounds as coming from persons they had hurt or who take care of them, negative emotions and hyperarousal related to the sounds disappear. So, Elena with his mother. Sounds elicited distress when the source was considered as coming from a voluntary action. This is the point, voluntary action. Distressful of the individual's needs and made by people who were dominant towards the individuals themselves. So, these all attributions are typical of persons with PD or with maladaptive schemas who think that other people try to subjugate, criticize, or humiliate them. So, a good diagnosis and a good assessment is important for treatment. because if we have patients with PD or maladaptive schemas, we must work on interpersonal domain. Thank you.
So, but it doesn't mean that everyone with personality disorders will have misophonia, correct?
Yeah.
You cannot expand misophonia, personality disorders, as all of them have misophonia.
No.
But a person with misophonia
Can
may have personality disorder, so they can be coexisting.
Yes, I don't know exactly what kind of personality disorder is probably OCPD, but I think also for avoidant personality or paranoid.
Excellent. Thank you very much.